Well, I'm Dr. Jim Del Rosso, the editor-in-chief of the Journal of Clinical and Aesthetic Dermatology, JCAD, that I like to affectionately call the Green Journal. Somebody told me that some time back, and that stuck with me. That resonated. And this is the September 2025 issue, and there are a variety of very good articles on many different topics. And I want to start with an article that's entitled Updates from the AAD and AAAAI Guidelines for Managing Atopic Dermatitis out of Chicago. Dr. Dharm Soda, Atitha Patel, and Dr. Peter Leo, well known to us. And this is a review of the updates in managing atopic dermatitis, the guidelines from both those organizations. So the group, the American Academy of Allergy, Asthma, and Immunology, their Immunology Joint Task Force updated their guidelines, management guidelines for atopic dermatitis from 2012, most recently. So after 11 years, they updated it in 2023. The American Academy of Dermatology updated their guidelines from 2014 in 2024. So that was 10 years. So collectively, these groups, it was 21 years total between their prior guidelines and their most recent guidelines. So there are a variety of similarities, and they cover many, many different areas: moisturizers, bathing, wet wraps, all different topical agents like corticosteroids, calcineurin inhibitors, phosphodiesterase 4 inhibitors, Janus kinase inhibitors topically, and then systemic therapies, Janus kinase inhibitors, monoclonal antibodies, conventional therapies like azathioprine, methotrexate, mycophenolate, and cyclosporin. And also oral antihistamines and phototherapy are addressed. They also look at some other areas, such as I saw here comorbidities to consider, allergy testing, and elimination diets. So it's a very thorough discussion from the vantage points of both groups that had a lot of leaders in their respective fields in atopic dermatitis. I'm going to suggest that you take a look at a chart on page 60, which summarizes the comparison between what the American Academy of Dermatology did and what the Joint Task Force on Practice Parameters from the American Academy of Allergy, Asthma, and Immunology. There are several similarities with some different perspectives and vantage points, but there are some differences, especially with regard to use of the conventional systemic therapies and the topical Janus kinase inhibitor therapy. That was more conservative on the allergy side than on the dermatology side. So I suggest if you're interested in atopic dermatitis at all, it's far too much information to summarize each point, but it's an excellent comparison between both those groups and their atopic dermatitis management guidelines. Another article that come from our friends, Dr. Joseph Marola, who is at the University of Texas Southwestern, and Alice Gottlieb at Mount Sinai in New York, with several other authors, including contribution from Brigham and Women's Hospital in Harvard Medical School in Boston, a group of authors with Sarah Romanelli being the lead author to talk about hidradenitis suppurativa, an experience related to the burden of musculoskeletal symptomatology. And they utilized the International Dermatology Outcome Measures Questionnaire to evaluate musculoskeletal symptomatology. Now, importantly, they didn't only look at symptoms, they did try to characterize as best as they could based on this validated survey parameter to look at what might be mechanical, right, in relationship to the disease state, the difficulties of the disease state, which often includes patients that have, they're many of them are overweight or obese, and that can be a factor in their mechanical stress versus actual inflammatory arthritis. So they found that just about 50% of these patients with hidradenitis suppurativa on that musculoskeletal symptom survey reported significant fatigue. They also, about 8 out of 10, had joint symptoms, but that wouldn't necessarily help you differentiate inflammatory arthritis versus some type of mechanical stress or change. But joint pain specifically was in a little bit over a third, with at least 7 out of 10. So 7 out of 10 or higher pain in terms of the extent of the pain, the intensity of the pain. So this was somewhat significant. Now, this was from a single dermatology clinic at a tertiary hospital between July 2023 and March of 2025. I think it's important in terms of raising our awareness that patients with hidradenitis suppurativa can certainly have spondyloarthritis and inflammatory arthritis that could lead to destructive changes on a long-term basis based on the inflammation and may warrant other types of therapy. So if you're seeing patients with hidradenitis suppurativa and you're interested in it, this focuses on that musculoskeletal aspect of the disease. Now, a third paper is actual single case report from Najeeb Natu, who I know very well, a dermatologist in the Orlando area in Maitland, Florida, also working in conjunction with Dr. Fahad Siddiqui, who's involved in the residency program at the Kansas City University Consortium in cooperation with the Advanced Dermatology and Cosmetic Surgery residency, also in Maitland. And they describe a 25-year-old male who had a difficult time over about 18 months with confluent and reticulated papillomatosis, which is something we occasionally see that can be difficult to manage. Now, we used to think that malassezia was a component and treat this with antifungal therapy. Occasionally they get partially improved, but it usually did not do very much because it wasn't a variant of tinea versicolor per se. Oral minocycline had been reported in the literature as being helpful, and this patient did have temporary help from the oral minocycline, but the disease came back and was persistent. So, in looking at the literature, the authors found that topical calcipotriene, they used a 0.05% cream once a day, and then tretinoin, 0.05% cream at night, also being once a day, led to significant improvement and persistence of control of the CARP, the confluent and reticulated papillomatosis. So this is a safe, effective, and readily available by prescription, both available generically, so should be easy for the patients to get at minimum cost. That proved to be effective. So I thought this was a very helpful case study. We sometimes forget about some of these other options. Another paper from Diego da Silva in Virginia as the lead author, who's at Forefront Dermatology, in coordination with several other dermatologists across the country, including myself as the senior author, looking at use of nemolizumab in patients that have atopic dermatitis, prurigo nodularis, or both, and even a few patients that have chronic pruritus of unknown origin. And there were 12 patients in total. Now, this was put together relatively soon after nemolizumab came to market, a subcutaneous injection that blocks IL-31, approved for first prurigo nodularis and then atopic dermatitis, collecting real world experience early on. Now we have further experience now, but this was a very nice summary of a group of 12 patients provided by different clinicians from cases they've had around the country that they have treated. In that collective group of patients, 5 with atopic dermatitis, 2 with prurigo nodularis, 2 with atopic dermatitis and prurigo nodularis, all together, those 2 diseases were both present in both of those patients. And then 3 patients with the chronic pruritus. The mean peak pruritus in the group was 9 out of 10. So these patients had significant pruritus, and the mean body surface area of involvement in the patients that had the visible disease was 45%. Over the course of the treatment with nemolizumab, the body surface area decreased to 4% and the peak pruritus to zero point 0.9, so just about one when it started as 9. So these patients demonstrated substantial improvement. There is a nice picture of one of the patients in the study. I do want to point out that some of these patients had been previously treated with other therapies, topical corticosteroids, systemic corticosteroids, including intramuscular triamcinolone injections, topical nonsteroidal agents, some of the different agents that are available, topical Janus kinase inhibitor use, and also patients that may have been treated with dupilumab, tralokinumab, cyclosporin, and some other agents, including Janus kinase inhibitors like upadacitinib. They had been on those therapies, and for whatever reason, they were not continued or weren't giving them adequate control, or there was some adverse events. Notably, in the vast majority of the patients, there was a definite improvement in itching that was noticed by the patients, typically within 2 to 3 days. So that was something that was beneficial to see, is that the nemolizumab gave a rapid response of noticing a definite improvement in the itching. And then over the course of the treatment with nemolizumab, these patients had substantial improvement. What I think is most beneficial, rather than just to get the summary points that I'm making, is each of the cases are reviewed. So if nemolizumab use is relatively new to you, or you have questions about what's actually happening with these cases, the authors walk through the individual course with each of those disease states and how the patients did, which I think is very important to see in more detail what happened in individual patients. So I think that was, with this being a newer therapy, a monoclonal antibody, uh, I think it's important for us to recognize that to develop experience with all these different agents. Now, another paper from Krista Bunik and Nicole Ozlowski, Chris is the senior author, is a single case report, but an interesting one, and one that we just featured at JCAD TV covering this in more detail. But it's utilizing the triple combination of clindamycin, adapalene, and benzoyl peroxide topically for a patient that was, let's see here, a 15-year-old female that was being treated for acne, that she had acne, milder acne, and then was enrolled for her atopic dermatitis into a study where she was receiving upadacitinib 15 milligrams a day. And she developed a worsening of her acne. Now, we know that the Janus kinase inhibitors, the systemic agents, can lead to acneiform eruptions and acne. This patient had pre-existing acne vulgaris, but that acne got worse. So we don't know exactly if it's the same acne vulgaris or a similar appearing acneiform eruption in that patient, but they elected to treat the patient with the triple combination topical, which happens to be under the brand name of Captrio, but it's the only way you can get that particular agent once a day for this patient to see if they can treat her topically, keep her going on in the study. She didn't want to stop because her atopic dermatitis was doing so well. And over the 20 weeks, she had substantial improvement of her acne, very good control. There was really no sequelae noted developing a scarring or any persistent inflammatory dyschromia after the patient completed that treatment of 20 weeks, and they continued on that triple combination topical therapy for the acne and stayed on the upadacitinib. So they were able to continue the study and control their acne eruption without changing the successful treatment for their atopic dermatitis and successfully controlling the acne. So this is a case report showing that particular approach that may be of benefit to you in clinical practice. Now, I'll end with just mentioning a few articles. One is on topical adaptogens uh, by a group that looked at many different studies. What are adaptogens? There are a variety of different agents, usually botanicals, that are in several different skincare products without a clear understanding of what they're actually doing. A lot of them are historically used or added based on their proposed benefit or suspected mechanisms. These authors looked at in more detail mechanism of action and the actual classifications of these different adaptogens. And they came up with 29 of them that they can characterize much more successfully. That you as a clinician, if you're talking to patients or utilizing many of these different products, skincare products, you are much more well versed in what these particular agents are doing. And there are 29 of them they identified. Some of them we are familiar with, like aloe vera, echinacea, melaleuca, resveratrol, theobroma, and several others. And they did a beautiful job of putting them into categories and coming up with what their proposed mechanism of action is in a much more scientific and organized fashion. An excellent article with regard to these botanicals, which are classified as topical adaptogens. A couple of other articles, a systematic review of topical glutathione. It has ended up being there are only 5 actual clinical studies. They tended to be small without control groups, but did suggest that topical glutathione may decrease hyperpigmentation and provide antioxidant activity, but there is limited data in the literature, so more is needed. If you're thinking about recommending hats in the United States that provide good sun protection, there was actually a study out of the Philadelphia area, Drexel University in a dermatology department, and out of Schweiger Dermatology in King of Prussia that looked at the hats that are commonly recommended to patients and promoted to provide sun protection and have what's called a UPF, an ultraviolet protection factor ascribed to them. Is that good information in terms of telling you how good that hat is in providing photo protection for the patients in the way we expect a hat might be able to do? And the answer turned out to be no. When they looked at this, they found that the structure of the hat, having a circumferential brim of 2 3/4 inches, and the what it's made out of, does it have any discontinuous areas within the hat, is actually more important than the UPF rating, which was inconsistent in terms of this assessment. And then a couple of other articles. One is a remission of alopecia areata post-colectomy in a patient with Crohn's disease from my good friend David Altman, the case report, along with his family nurse practitioner, Caroline Sulich Moore. Very interesting case in a patient that had Crohn's disease and alopecia areata that ultimately the alopecia areata responded with significant regrowth only after the patient had a colectomy. And then another article, if you are interested in psoriasis and occupational exposures that may lead to precipitation or worsening of psoriasis, it's one that I would not have thought of, but it's the association of psoriasis and occupational organic dust exposure. I don't know that that's kept many of us up at night wondering about it because we probably haven't thought about it. But this is a cross-sectional analysis from the National Health and Nutrition Examination Survey from 2009 to 2012 amongst U.S. adults. The amount of organic dust exposure doesn't lead to a greater observation of psoriasis or worsening of psoriasis. And it turned out that it did. compared to individuals that did not have the significant organic occupational dust exposure. And it was shown to be even worse in females. So there was some statistically significant association with the occupational organic dust. If you are treating a lot of patients with psoriasis, you have patients that this may influence, it'd be worth looking at this article. So I'm going to stop at this point and hope this provides you some insight into the articles that the journal has in September 2025. But the information is going to be more so in the details within those articles. So if any of them pique your interest, I suggest you read them. They are all available online. JCAD articles are available on PubMed or by going to the website and looking at the current edition. Thank you very much.